Good afternoon. Good afternoon, everyone. It's wonderful to see people in person in 3D. Great, and thank you for taking the time out of your busy schedules to join us. I know we have also a number of people who elected to join virtually, and that's fine as well. I'm Paul Irwin. I'm Dean of the School of Public Health here at UAB, and I want to welcome you to the 2021. It's happening in 2022. I haven't messed up. The Carole W. Samuelson Endowed Lectureship in Public Health Practice. This lectureship was established in 2002 at the UAB School of Public Health by family, friends, and colleagues to recognize Dr. Samuelson's courage, tenacity, and leadership in promoting quality health and educational services to the public. Dr. Samuelson was born in 1941 near Greenville, North Carolina, and died February 14th, 2009. She was a pediatrician and the Jefferson County Health Officer from 1985 until her retirement in 2002. She was a 1968 graduate of the University of North Carolina School of Medicine in Chapel Hill and completed her residency in pediatrics at the Strong Memorial Hospital in Rochester, New York. Dr. Samuelson joined the Jefferson County Department of Health in 1975 as a part-time physician. Within 3 years, she was directing both of the county's primary care clinics. She was promoted to director of the primary care department and then to administrator of the entire health department in 1985. This endowed lectureship honors Dr. Samuelson for her outstanding service through years of devoted commitment to the Jefferson County Department of Health, as well as many other community and statewide organizations and interested in providing quality health care. Throughout her professional and community activities, Dr. Samuelson led with diligence and innovation while always placing the public first. This lectureship was created to honor her passion for excellence, as well as to continue her tradition of intellectual innovation and community involvement. I'm so pleased that Dr. Paul Samuelson has joined us once again to show his support and his connection to not only UAB, but clearly his beloved wife, Carole. So Paul, great to see you and glad you're here. I want to also acknowledge in the crowd that we have Dr. Scott Harris, who is the state health officer, and Dr. Mark Wilson, who is the director of the Jefferson County Department of Health. If you and any other employees of either of those health departments or any other health department are here, would you please stand up? Please join me in thanking you. You folks are our heroes. The time, the commitment, the energy, the blood, sweat, and tears that you have given over these past 2 years. I can never say enough good and positive things about. It is an honor to have you here in this room. Thank you. I also want to acknowledge 2 members of the Broad Street Committee who are here. The Broad Street Committee is an advisory committee to the Dean's office at UAB. Dr. Cameron Vowell is here, and Dr. Mark Wilson is also on this advisory committee. And it's the advisory committee that provides a recommendation to the Dean's office for the selection of the lectureship. And so with that, let me introduce today's lecturer. Dr. John Wiesman is a professor of the practice at the University of North Carolina Gillings School of Global Public Health, Department of Health Policy and Management. He teaches leadership, health policy, and advocacy, and serves as the program director of the Executive Doctor of Public Health DrPH degree program. This is the program that both John and I graduated from. I was in cohort number 2, John was in cohort number 5, and they are just now admitting their 18th cohort. Prior to this appointment in July of 2021, just last year, John served as the Washington State Secretary of Health for 7 years where he led the nation's response to the first case of COVID-19. While serving as secretary, he implemented a gender X option on birth certificates, spearheaded raising the legal age for the sale of tobacco and vape products to 21 years, implemented an Infants at Work, I guess that's not an Infants to Work program, and led the effort to include the state's 29 federally recognized tribal nations into legislation, making them eligible for foundational public health services funding. And in an interview that I did with John, he showed me some of the gifts that the tribal nations had given him in honor and in recognition of your work with the tribal nations. It's fantastic, John. He has worked in 4 local public health departments in Washington and Connecticut. He started his public health career in Connecticut in 1986 and was in its first group trained to provide HIV counseling and testing services. John has been passionate about public health since reading a 1983 Time magazine article about disease detectives tracking Legionnaire's disease, toxic shock syndrome, and HIV. This was the impetus for him to enter the profession. John co-chairs the Presidential Advisory Council on HIV/AIDS. He has also served as president of both the Association of State and Territorial Health Officials and the National Association of County and City Health Officials. John, you may be one of the only persons to serve as president of both of those, representing local health and state health departments. John was born and raised in Wisconsin. He and his husband, Ted, who's here, thank you, Ted, for joining us, live in Durham, North Carolina. John Wiesman, welcome to UAB. Congratulations on receiving this endowed lectureship recognition. We're excited that you're here.
Great. Thanks so much for that, Paul. And everyone who's joining us today here in the auditorium and also online, thank you so much for joining us. It's a pleasure to have you. And it's really a pleasure to be here at UAB. I've had a chance to meet some of the faculty and students today. They are incredibly engaging and wishing everybody really well in their work. And it is an honor here to be able to give this lecture in honor of Carole Samuelson, who is an amazing public servant, one who I think any of us could look up to and just wish we could probably achieve half of what impact that I'm sure she had. So thank you for that. And Paul, thank you for being here. Much appreciated. I just want to acknowledge too the privilege that we have to be here today to either have this conversation or online, given all of what is happening in the world, whether that be the conflict in Ukraine or just the challenges people have. It is quite a privilege for us to be able to have these conversations, to do this kind of thinking and learning. And I just want to acknowledge that that is something that hopefully we can appreciate today as we are here. And also the last 26 months truly have been incredibly and extraordinarily challenging and difficult for so many. Like Paul, actually, and these are in my notes, I did want to thank our public health and healthcare colleagues and all of the essential workers out there who have been on the front lines doing this work for now, I think something like 26 months if you take it from a Washington state perspective. So thank you for that. And just acknowledging the toll that this has taken on folks, whether we have lost someone to COVID, whether we've had COVID ourselves, folks who are struggling with essentially the long-term effects of COVID, and clearly the strain on all of us and the mental health challenges we're experiencing. So hopefully we are doing our best to take care of ourselves and just give people space and some gratitude. So as we talk about this, for those of you who have been working in this, it's certainly possible that this might stir up some feelings or emotions for you. If that's the case, please do take whatever time you need to just be with yourself and breathe into that. The topic for today, leading in first position of COVID and beyond, really is about when you are first out of the gate, when you are in new territory, and what does that take in terms of leadership, and what are some of the challenges you face? how are those similar or different to just other leadership challenges that we face, even with maybe routine things that might be something we know more, for example, like a measles outbreak, which is a big deal and can be a big deal, but it's something that we know about. So there are lessons, I think, that cross both of these. And to be really honest with you, this leading in first position is the thing that I had hoped to get out of my career never doing. I would see my colleagues in Texas, for example, leading the Ebola response. And I was like, oh my God, I'm so glad I'm not David Lakey today. And I hope that never happens. Well, I missed it by a year. So I will say, though, that I'm really pleased that I didn't find this challenge on the first day or the first year of my job, which frankly, many of my colleagues around the country literally were, some just in their first few days on the job. So something that I have to be thankful for. I do hope that today's talk will have a chance to dialogue and ask questions. I'm going to do my best to move as quickly as I can. And so recognizing that we have experienced a lot as a nation, we're going to talk about the first weeks of the US COVID response from the Washington state perspective, identify some of these leadership lessons that were either learned or reinforced and that others may be able to take with them, briefly touch on situational leadership style, and then have this dialogue. But recognizing that we are where we are today and we have this experience, I do want to sort of take us back, if we can, and take us back to January 21st of 2020.
Welcome and thank you all for standing by. All lines will be on a listen-only mode until the question and answer session of today's call. At that time, you can press *1 to ask a question from the phone line. I'd also like to inform parties that the call is being recorded. If you have any objections, you may disconnect at this time. And I'd now like to turn the call over to Mr. Benjamin Haynes. Thank you, sir. You may begin.
Thank you, Sarah. And thank you all for joining us for today's telebriefing regarding CDC's 2020 novel coronavirus response. 2019. We're joined today by Dr. Nancy Messonnier, Director of CDC's National Center for Immunization and Respiratory Diseases, and health officials from the state of Washington. Dr. Messonnier will provide opening remarks before taking your questions. I would now like to turn the call over to Dr. Messonnier.
Good afternoon, and thank you all for joining us. During our briefing last Friday, I foresaw that we could see a novel coronavirus infection in the United States, most likely in the capital of Washington. Today, I'm joined by representatives from the state of Washington to announce that we have now confirmed the first case of novel coronavirus in the United States.
And thus it started. In the telebriefing, that is what you call leading in first position. And I must say, when I was putting this together and listening to this, I literally had tingles going through my body of just sort of remembering what that time was like. So later in that day, we held a press conference and in this photo, you see Governor Inslee leading the way with myself and then the health officer in Snohomish County. And that really is what started the whole event. And I don't think any of us could have imagined back then what these next 2 years would have really been like. So leading in first position, I said it started there, but actually let's just take you back about 40 hours, 8 hours before that. On leading in first position minus 2 days, on January 19th, a 35-year-old male reported to an urgent care clinic in Snohomish County who had 4 days of history of a cough and fever. And he had been in Wuhan on January 15th. He had come back from Wuhan and flew through SeaTac Airport. And he saw a health alert from the CDC about this thing that was happening in China and symptoms, and recognized, hey, I have these symptoms, maybe I should go see a healthcare provider. So for our first case that was identified in the US, and of course we now know there were cases before this one, the public health response actually worked. Here was an individual who got some health information and did the responsible thing by going to see a healthcare provider. And that was absolutely exactly the way we want this to happen. And as it always so goes, so saw the healthcare provider consult with CDC on whether or not to actually send a blood sample for them to test. And in truth of the matter, this individual did not meet all the criteria for testing at CDC. Had not been in the market that was of concern, nor had been in contact with anybody who knew that he knew was sick, which were at the time some of the criteria we were supposed to be using to send a sample. But out of an abundance of caution, that sample was sent. And I was notified on that Sunday while having brunch at a friend's house that, you know, we have this individual out of an abundance of caution, we're going to send a sample to CDC. You know, when your health officer tells you abundance of caution, we're not overly concerned. I probably should have had my guard up a little bit more than I did. I did, however, notify the governor's office that we were sending a sample, you know, just out of abundance of caution. That sample was flown to CDC that afternoon and night. And on Martin Luther King on the 20th, CDC tested that sample and indeed it came back positive. So everything started there. Immediately within an hour, we are on a phone call with CDC, with the local health department, and strategizing our next steps. And on that phone call, you know, they said, we were wondering who was going to get the first case, and we're glad it's you all. You may not feel that way right now, but we're glad Washington's public health system is fairly strong. I don't know that that was particularly comforting to me, but we did start. And on that call, we immediately started talking about the response and when it was going to be announced, and agreeing it would be announced the next day. And also CDC asked what kind of assistance we would want. And I'll come back to that in a second. Within by that next morning, so this is happening now in Pacific time, like 3-4 o'clock in the afternoon. So it's, you know, later out here. The first flights in the morning, we had three CDC officials on the flight coming out to join us. And that gets me to my leadership lesson number 1. Don't go these things alone. Do not let your pride get in the way. There are many health officials, I think, who would say, we're good, we've got this, you know, we're in control, we are in the lead, we know the response, CDC, you stay there, we'll call you if we need you. We took the exact opposite approach and said, no, we all need to be on the same page. We want folks with us who can actually communicate back. So partner, and you've got to start by having everybody on the same page. And work really hard to keep them there. So that phone call was about, what do we want? And we said, absolutely, we want you to send some people out, be with us. We want no daylight in messaging. We want no daylight in understanding the science and how we're going to approach the response. Lesson number 2 is, when you are first, keep your counterparts informed and support them when it's going to be their turn to go next. So you might imagine, of course, everybody around the country is very interested now. All of my colleagues in the other states and territories are wondering, how are you responding to this? What are you doing clinically with this person? You know, how are you going about case and contact investigations? So you're going to have this additional role if you are leading in first position to help others come along and to learn from also what they're thinking. They can be a sounding board for you as well. So in that then sort of brief time period that I've got on this timeline here, the first case we had to figure out which were going to be the protocols for case and contact investigation. This is a new disease. We don't really know when someone's infectious. You know, from other coronaviruses, we know people were infectious once they started showing symptoms. But are you infectious before that? Well, we didn't really know. There wasn't really enough experience. We knew there was some human-to-human transmission, but it seemed to be limited. Like, how much time do you have to be around somebody to become infected? And like, how close do you need to be? All of those things we had to figure out some kind of answers to by being in first position where we didn't have all the data. We had to figure out how we were going to do case and contact investigation. And to do that, you got to know, who are you going to call a potential case or potential exposure? right? So this gentleman had gone to a restaurant while he had some symptoms. So was everybody in that restaurant at risk? How close did they need to be? Were people at risk after he left for a period of time, like with measles, where you can be in a room for 2 hours afterwards and still catch the infection? So those were decisions that we had to make without all the kind of information we would want. Treatment protocols we had to figure out with our CDC colleagues, which is one of the reasons we wanted them there, was for the clinical management. What were we going to do clinically? We were faced immediately with a decision. This gentleman was actually pretty well and didn't need hospitalization. You know, he went to a clinic because he saw this health alert and thought, I should probably go. So the question was, do we hospitalize the patient? If we hospitalize the patient, who's paying? Is insurance going to pay it? I mean, the guy doesn't really need to be in the hospital. You know, doesn't need supportive care. If the insurance doesn't pay, will the federal government pay? Well, nobody can answer that question because, you know, it's a big bureaucracy. Nobody knows for sure. So I was in a position where I said, look, I think the best thing is to ask the gentleman to go to the hospital, and we can put them in the isolation wards, which were created exactly for this kind of situation. Ask the individual to go so that we can monitor him. And if nobody else pays, I don't know how I'm going to do it, but I'm going to pay, right? Like, this is not the time to be arguing over payment. And frankly, we had to learn a lot about this disease as well. What's the clinical course? And what a better way to do that than to have the person, if they were willing, and this person was extremely cooperative, to go to the hospital. So then, you know, we're sending samples to CDC based on the criteria of who might be at risk, and we're not getting any positives. So we did about 80 some contacts with this individual. None of them turned up positive. And between January 21st and February 8th, and I'm thinking to myself, oh my gosh, did we like escape this? Like, this seems amazing. Well, on February 28th, an individual from the Seattle Flu Clinic study, or flu study, which is a general surveillance study looking for new flu strains, tested their samples for COVID, which they really weren't supposed to be doing because you needed FDA kind of authorizations to do this, and found a positive test. And it was in a high school student who was just about to enter the school building when he was found and essentially prevented from going to school. So this raised an interesting issue because, number one, the research protocols really didn't allow this testing. And so some of the question is, what do you do with this? Well, we've got to act. We now know we have a positive test, right? Like, we can't just do nothing. The school, not in accordance with our advice, closed for 2 days to do full cleaning, et cetera, when essentially the student had not yet even gotten into the building, or if he had, it was just like in the entrance. But the point is, there was, again, abundance of caution. We're concerned. We are hearing about all of these deaths in cases expanding rapidly. Later, it was learned through testing that strain that the individual had was actually linked to the first case. They have nothing in common, right? So it's clearly something was going on. Now, that wasn't known at the time. So then come February 29th, we've got some more cases being reported. First cases coming out of a nursing home. Again, no apparent connection to these cases. And there was a death that occurred in a hospital from this coronavirus, which also was not linked to the nursing home. So all of a sudden, our awareness is like, okay, there's a lot more of this out there than any of us know, and the testing is just not, broad enough, wide enough to be catching this. So also on that date then, the governor declared a state of emergency, and declared a state of emergency to be able to get resources to free us up from some of the bureaucratic sort of administrative processes that you need to follow outside of regular emergencies. Then you can see we had more new cases on March 1st. By March 7th, we had 136 cases in the state and 18 deaths. And so this was, this is a point where I knew this was big, and we were just seeing the tip of the iceberg. And so based on that, we are having many conversations around what to do in terms of community mitigation measures. We had been briefing our governor and others about what does that even mean, right? So that they're prepared to act. On March 11th, we banned social, spiritual, and recreational gatherings of over 250 people. Why 250 people? I don't know, because we were trying to ban large gatherings. What is the right number? Nobody really knows. And so we are having a meeting on a weekend with the mayor of Seattle, with the King County executive, which is of that county, of the governor, myself, modelers who are showing us data based on what we now know about cases, just how big might this actually already be? And if we don't act today doing something, what might likely happen in the future? Again, using assumptions that they're not fully familiar with. So on the 12th of March, schools closed across across 3 counties. They decided they were going to close on their own. Again, we didn't ask for that to happen, but once that happened, that basically set off everybody else. And so the governor then ended up closing schools at that point in time. And then we also ended up closing restaurants and entertainment facilities, as you can see there. And banned gatherings over 50 people, because we thought this is bigger, so we ought to go for a smaller number of folks to ban. The point again is you're needing to make decisions when you don't know all of what you need to know. And then the governor issued a stay-at-home order on March 23rd, essentially shutting down in person for any non-essential business. And you might imagine trying to figure out what an essential or a non-essential business is, and giving the guidance to that. And those of you who are in the room who have done this, you know exactly what we're talking about here. Then just to give you a sense of this nationally, so March 11th, the World Health Organization declared this a pandemic. And then by March 27th, there were 509,000 cases already worldwide, and 23,000 deaths. So this is, from December 31st, where the first sort of report of this out of China, to just those 3 months really grew rapidly. And of course, now, we all have hindsight to be able to understand this in a way that we didn't before. So leadership lesson number 3, lead with humility and transparency. In this case, you're leading in first position. You know you don't know everything that you need to know. You need to let people what you know, and let them know what you don't know, and what you're doing to try and figure out those answers. And lead with humility in the sense that you've got to understand yourself. There's a lot you don't know, and you do need to project confidence in front of the media and give people what they know. But you have to make sure that you are doing this with the understanding that you do not have full knowledge, and that you're going to learn a lot as you go. Leadership lesson number 4, it's about the people. What policies do you need to implement to mitigate the negative consequences? There were huge negative consequences to these community mitigation measures, right? Which we in public health feel, and I still feel today, were absolutely essential. But in order to minimize other harms, you've got to, as a policy person, think about what else has to be done. So those policies were things like we extended unemployment benefits for folks who, I forget, it was like you had to be unemployed for 2 weeks or something in order to get benefits. And we said, we're going to shorten that. And so the governor, through executive order and his emergency powers, shortened the period of time, in part because we now needed to ask people to stay home if they were exposed. Well, if you live paycheck to paycheck, asking you to stay home is something that truly is not an option for many people. And so we tried to extend unemployment benefits to try and address that. Moratorium on evictions, right? People are no longer, some of them no longer able to get their income. So a moratorium on evicting people from their housing, right, through emergency powers. that nobody could be cut off from their utilities, from their heat, from their electricity. If somebody was high risk and they could not work at home, that they could get unemployment compensation and that their job had to be held for them when it was okay for them to go back to work. So an employer might find somebody else to do the job in the moment, but their job was guaranteed to go back. So the point being, you have got to work through what are the mitigation measures for some of our public health measures. And you have to work through whatever legal processes you have to do that, whether a governor has an emergency authorities, whether you need legislative approval. And the concern right now is that lots of legislatures are cutting back authorities of governors to be able to operate in emergencies. And their public health folks, which is really going to be limiting some of our ability to respond quickly. Leadership lesson number 5, every crisis has opportunity. And as a leader, you've got to be prepared to take those. For us, that meant our data system challenges were horrendous, like many others across the country. We were operating on legacy data systems that were not in the cloud, that could not handle the kind of volume of case reports we were getting. And we had been requesting, right, like through the legislature for a number of legislative sessions to upgrade data systems, move to the cloud. This was the opportunity to move our data systems to the cloud under normal circumstances would have probably taken 3 years for sure, maybe 4. By the time you go through the budget approval process, biennium, get approval, you go through the applications, we had the data on the cloud in about 3 months. And that only happened by Microsoft and Amazon and everybody helping us get there. And our staff, who are working like crazy, just trying to keep our data systems up, know how important this is, and also knew that this was an opportunity to try and get where we needed to go. So while they are literally burned out, they are moving forward on it. Funding public health, it became clear that the testimony I've been giving to the legislature now for 5 years, telling them the public health system was crumbling. We have done study after study with you, telling you that we need $300 million more invested in the local and state public health system. This was the opportunity to move that forward. And on my last committee hearing to the healthcare committee, the chair said, "You can tell us you told us so." Now, I would have liked not to have been in that position that they listened earlier, but it was an opportunity. There were also opportunities around remote working, right? Better work-life balance for folks. We're reducing, the impact of climate change. We have fewer people out there, driving an hour and 2 hours, whatever, to work. So some of these are things that we as a society really need to be thinking about what makes sense moving forward. Which of these things did we learn we could actually do that we had said for ages? How many supervisors have I met with who said, there's no way I can supervise somebody from home. I got to see them in their seat here at work. Well, we found out that you could, and in many cases, productivity increased. Now, is that due to fewer, less unimportant meetings happening, fewer water cooler conversations taking up time, which does have some negative benefit? I mean, there's positive to those water cooler conversations. You learn things about work that you didn't and that you ought to be thinking about. Or I see Paul and say, hey, I've been meaning to talk to you about this, right? That doesn't happen so much on Zoom. So every crisis has an opportunity, figure out how to use it. Take your strategic thinking and planning and turn it into adaptive strategies. So in preparation for this lecture, I was looking up some of what Carole had done in her work. And she published an article with the folks at Jefferson County Health Department, preparing for the future in a local public health organization. And in that article, they say one of the most difficult issues in strategic planning in public health organizations is how to harness the energy generated in the process of strategic thinking and focus it on strategy formulation. And they say adaptive strategies outline the major strategic emphasis to be placed on each program in order to move towards the accomplishment of the department's mission in light of the future visualized for the community. And in this case, this was an article about sort of budget cuts during the Great Recession and what to do in terms of services. Do you scale back some services, end services, put more resources in this service and scale it up, right? So there was this adaptive and strategic thinking. That is exactly what was needed in this effort, and in part in advance of needing to lead in first position. It became clear to me that our threats of the public health system with reduced workers at the local level, with the global transportation that we were seeing, experiences from SARS and others on just how quickly infectious diseases can affect the globe, said we have got to invest in emergency preparedness and response, which the country had done. But when I took over this department as a state, they saw themselves as a planning agency. In my mind, it was like, no, we need to transform ourselves strategically into a response agency, because our local health departments are losing employees. They don't have the capacity. Who are they going to turn to for resources, right? So definitely the strategic thinking helps you if you have been looking to the future in advance for when you're in this position of leading in first position. Leading in first position, lesson 7 starts well before you find yourself in the first position. You have to be intentional about the kind of leader you want to be, because who you are beforehand is how people are going to experience you here. And this is something that really, as individuals and as those of you who are looking to move into practice careers and leadership roles, want to think very carefully about. For me, one of the things, and Paul and I had an opportunity through this, some work he's doing that he mentioned, to talk about the importance of presence. For me, presence is incredibly important in my leadership role. And what do I mean by that? I mean by, first of all, spending time with people, and really like spending time with people, like close the laptop, put the phone aside. When as a leader, I'm in a meeting with folks in community, really sit and listen, hear what the issues are for them and what the intersects are from a systems perspective. And the concrete example of this, which leads to some of what Paul said, is that the tribes have every 2 years in Washington State a health planning couple of days where they get together, and as the 29 tribes, they actually do this joint planning with the state. It is typical for someone in my position to come in for their presentation, do their presentation, and leave. I knew that these are tribal elected officials and their health people, that this is a big deal for tribes. And how many meetings have they come to with me where the issues for them are 5% of what's on the agenda, but they're there, they stay there, and they're engaged. I stayed for the 2 days with them, and it brought amazing credibility. And honestly, if I'm saying that, truly we want to think about health equity in our state, tribal nations are an important piece of that. And by physically being there, listening to their issues was incredibly important. And it led to this piece of being presented with a blanket at the end of the meeting, which, as those of you who have worked with tribes know, that's incredibly important. And it built the credibility. It also buys you forgiveness when you screw up, because you're going to screw up at some point, right? And I screwed up on some tribal things. But the fact that I took the time, that I cared, and that I could understand where I screwed up and apologize was incredibly important. So as a leader, it's important for you to think about what is going to be your leadership style. And that comes to sort of situational leadership and how we approach the response to this. Those of you who know situational leadership, basically it says that you want to focus on the individual, understand their ability to do the work and their confidence in it, their commitment to it, and that you assess the individual employee. And then as a supervisor, you figure out your leadership style with them on where they are. So in this chart here, for example, you would delegate to somebody who's got the followers competent, they've got the skills, they're able, and they're really committed and willing to do this. And so a delegating style makes sense versus a telling style where you would tell somebody who really doesn't have the competencies and they're unwilling and unsure of themselves. You have to give them clear direction. In this response, we used situational leadership in a different frame instead of looking at the individuals, because I had an amazing incident management team who responded to over 24 major responses in the in the 7 years I was secretary, responding to massive mudslide, which killed about, 40 people in a community, to measles outbreaks, to 8,000 pain clinic patients all of a sudden not having access to their healthcare provider because of the medical commission pulling their license. I had people who knew how to do this, but I had to take a very different role. I could not just delegate to them because the situation was changing so rapidly. It was a new virus. I had to now look at the situation and figure out my style based on the specific issues. And so the situational leadership wasn't about how is Paul capable of doing this, but rather what is the situation demanding of me at that time. And I took a very different role than I would normally take in a response. So we now know, coming back to today, just what it is we were ahead, what was ahead of us. And honestly, I have to tell you, even as a public health professional, I couldn't wrap my head around this as I was going through some of this, just how big this was, how long this was going to take. And I had an amazing governor who, because he was not trapped in my day-to-day trying to get this to work, could see that and pushed me constantly to think bigger. Like, you all are not thinking big enough. You all are not thinking big enough about vaccine distribution, right? Like, you are not going to be able to do this just through healthcare providers. So that hindsight is incredibly important, which now leads me to the last couple of leadership lessons. Leadership lesson number 8, take time for yourself. Be careful not to lose yourself if you are leading in first position. Let me tell you what that means from a personal place. My job became literally 99.5% COVID, which, as a leader of a billion-dollar budget agency for a 2-year period and 1,800 employees, would not be normal. And it was that way for the entire year that I was there leading this response. Every waking moment became COVID. And I tend to be an introvert and a more humble kind of person. People had to help me understand that, yes, you need a driver. You need a driver who actually picks you up at your condo every morning, takes you to wherever you need to go, and is going to drive you home. Why? Well, a couple of things. One, there were calls and things that had to be done, right? Every moment of my time was precious. 2, people were concerned about me falling asleep driving, right? Like, we've got to take care of, but it was so foreign to me. Like, right, I'm a public servant, right? Like, people don't bring me lunch. My secretary doesn't bring me lunch. Well, we were making lunch for everybody in the response. But what happened throughout that is I lost all daily routines. I lost any sense of anything except COVID. And I was waking up literally, my husband's here, he can confirm it, literally at 2 and 2:30 in the morning in a cold sweat. I fell asleep just fine because I was exhausted. But come the middle of the night, I woke up right out of my sleep, absolutely panicked about how are we going to get the data out of the system today. Staff are struggling. We don't know how we're going to do this, or the cases are going back up. What's the next community mitigation measure we're going to implement to try and get a handle on this? And how are we going to make that happen? And I had anxiety that I've never had in my life. In one weekend, I reached out to my healthcare provider and said, I can't function. I can't lead. I don't know what is the next thing I'm supposed to do. And thankfully, telemedicine now had kicked in. I got an appointment with a clinical social worker at 10 in the morning or 10 in the evening, had an amazing sort of conversation and practical strategies to help me deal with this. One of which was, when you wake up in the middle of the night, don't go do your work email, which is what I was doing. And when I did that, I found the adjutant general online also working. I found my colleagues across the country sending emails. She said, you've got to get up, do something mundane, and fall back to sleep. That practical helped. And then what I was able to do as a leader was to share that with my staff and be authentic, because I knew they were struggling. And I had to say, I'm struggling too. Here's what we can do. Here are our resources. So you have to take care of yourself, which I learned because I had lost who I was. So I started playing cards again on the weekend with my husband, taking some time out to do the things that I would have normally done. And you have to help take care of your team. Most importantly, when you lead with equity. Everyone benefits. This response that we had, our systems weren't prepared to lead with equity. Those migrant farm workers, how the heck are they supposed to stay home and not go if they've been exposed to somebody at COVID to go to work? Somebody who's living paycheck to paycheck. How is somebody who lives alone, who's supposed to quarantine, but they have a dog, they don't have much money, they need groceries, they can't Uber Eats out. How are they supposed to survive? When we build systems for those who are least able to care for themselves, we actually build systems that work for everyone. And if we don't learn anything in this response, this is one we have to take to heart. And with that, we are open for, unfortunately, not quite as much time I thought to dialogue, but we would love to have questions, dialogue, both from you in the room and then if there's anything online. So thank you very much for being here today. So do we have any questions in the room to start with?
Yeah, let's start with questions in the room.
So the question is, and we're repeating this for folks who can't hear online, how do you lead with equity? It's important, obviously, but how do you actually do it? And is there an example that we have? So an example of what we did do was start a pilot project of being able to bring in community health workers into people's homes who were needing to quarantine to help them connect to the services they needed. This wasn't really a part of the system before. We also tried to get, and I think eventually did, but it took way too long, to get money that we could just give them money because they're not able to work, right? And to get benefits, you've got to wait, you've got to apply for benefits, right? So this was about trying to get cash immediately. So those, it's like, how do you build a system like that? And if you build a system like that for those who are most vulnerable, everybody somehow in the system, you're going to have actually taken care of. So part of this is getting really concrete to do that. So that's one just quick example.
Don, I have a
Yes.
question for you.
Yes. Do you want to ask it up here and then don't have to repeat it?
So it's the proverbial Monday morning quarterback question. Knowing what we know now, what could have been done differently in the early days, perhaps the first couple of months, that may have resulted in a different outcome? And I stress may.
Yeah, that's a really good question. I mean, there are so many things we could have done differently. One, let me just start with some bigger system issues. One is we've got to understand that infectious diseases are a national biosecurity issue. And that as a country, we have got to be prepared for those and to be able to sort of go our own in many ways. By that, I mean, for example, personal protective equipment, right? We have got to figure out in this country how to have better stockpiles, how to be able to, if we're not going to produce these things on our own, how is it that we have systems in place that we can immediately retool a factory and it's ready to go, it's primed, so that because in the beginning days, I mean, look at nursing homes. If we had had personal protective equipment for the folks who are working in nursing homes, we could have prevented a lot of infections, but we had people who were working with nothing, or taking a scarf they sort of found somewhere and trying to, put it over their face. So we've got to sort of think on those kind of levels. I think we have got to understand how to better communicate, how not to have any daylight between whether it's the federal government, states, et cetera. This was extremely harmful, especially as this response went on. They're just like 1,000 of these things. So what we have to do is take these after action, during action lessons now, and start operationalizing these. Data is another one. We have got to get our data systems functional, that we aren't operating on information that is so old you can't make any sense of it. And we've got to have data systems that get to the demographic information at a very granular level. It is not okay for us to just be asking, are you Asian, Hispanic? This is not helpful when you are looking at a response. You've got to understand more at the ethnic level what's going on so you can understand where the hotspots are. And one policy that is controversial, probably will never happen, but we need in this country a single unique health identifier for every individual that is connected to a demographic database that healthcare providers and public health have access to. Why would that have made a difference? Because if you're in a case like this and you've got a blood sample going to the lab to be analyzed, hardly any information is coming in on that in terms of the patient's contact information, what language do they speak, how do you get a hold of them? So if you're trying to do case and contact investigations and you got this report and you're supposed to respond to be effective within a couple of days, it ain't happening, folks. And why do we keep asking people to do this every single time they come to their provider? And we don't know what language they speak. We don't know how to get a hold of them. So if we had those kinds of sort of systems in place, everybody would benefit. Your healthcare provider would know when you came into the clinic, if you're a new patient, what language you speak. How do I help them from day one? So and my colleagues would probably name 10 others and maybe even more important ones than I did.
We have another question up here, and then Dr. Harris.
So as a student in the UAB DrPH program right now, I just learned that I believe that lobbying for part of the federal public health department is not allowed. And so I just would like to know, is that true, and why do you think that is? Because would it help us receive more funding for health departments?
Great. So the question really is about lobbying and what you can and can't do. It is true that you can't lobby on sort of usually public funds to the state legislature or to the federal government. You can't use grant funding to do that. Nonprofits have some leeway in how much lobbying they can do. So the path forward here is sort of twofold. One is you can educate. And you can educate your elected officials by helping them understand what the issues are, what options they have in front of them. And as long as you are not sort of advocating for them to pass a certain bill or do something, you're really in the education frame, and that is totally allowed. Then, you can lobby on your own time in your own way, not using these resources or not using, the telephone in your office, right? So there are ways you can do that, and coalitions you can join or support who are doing that lobbying. Does that help?
We'll have a final question for Dr. Harris.
John, thank you so much for being here. That was really terrific. I would just really appreciate any thoughts you have about something we haven't talked about, but just the whole misinformation, disinformation industry. That's the one problem that we face. It's actually not improved and it's continued to get worse. And I would just appreciate any thoughts you have.
Yeah, so the problem with misinformation and disinformation, it is huge. So on the piece of social media, et cetera, I don't think there's any way to get around it other than regulating it. Somebody's got to step in and say, we've got to regulate. It's clear that folks aren't able to do this on their own. And it's going to be really challenging even if you regulate it. Technology is changing, by the moment and how you do that. But that's absolutely essential. I think then, beyond that, it's the disappointment here is how our elected officials are participating in it. Like, that is not okay. I don't know what to do about it, but somewhere, somehow, people have to stand up, and the people who are also elected officials who have influence over folks and say, this is harmful. This is also why public health needs a whole lot of other bright thinkers from technology fields, communication fields, political science, who can help us figure these things out. But it is one of the most dangerous things out there. And we're seeing that now. We're going to see probably fewer childhood vaccines being given. We're going to see likely more, vaccine preventable illnesses down the road because of this. And that's just, the start. And public health's work in this space around policy, around regulation, public health professionals are going to be afraid now to do some of the work that is our work, because elected officials have scaled back their responsibilities or authorities, or you're just the nanny state. We're at a crisis in supporting our public health system.
Well, I hate to leave it at a crisis. Please join me in thanking John Wiesman. So thank you all for taking your time to join us, and I bid you a good rest of your afternoon. Thank you.